When it comes to testosterone, male versus female, very different reference ranges, but let's just start with testosterone in general. There's a total testosterone lab marker, and then there's a free testosterone one as well. We look at both. Total testosterone refers to the amount of testosterone you have available in your body to be used, but it's not actually bioactive and going into its derivatives for functional purpose. That's what free testosterone is and does. So we measure the two and we keep an eye on both. So total testosterone for an ovulatory female, for a premenopausal female, normal might be somewhere around 50 or so. I've got reference range units and nanograms per deciliter, okay? Your free testosterone, normal may be somewhere kind of around 3 in picograms per milliliter. We're looking for something about that functional. When it comes to perimenopause, obviously that transitions downward. There's not really a reference range we're looking to in terms of what's your normal, what's your optimal, well, not your optimal, what's your normal in perimenopause, I should say. When it comes to postmenopausal females, we just naturally see that decline. And oftentimes it's not rare for me to see a total testosterone less than 10, a free testosterone less than 0.5. What I tell women is when you're premenopausal, when you're ovulating, we want to check your testosterone around your cycle date capture 13 to 15, because that's when it's going to peak. And if you think about that, that makes a lot of sense, because when you release your egg and you ovulate, if the purpose of your cycle beyond the metabolic health benefits is for fertility impact, we want you to have a libido surrounding that egg release. And libido comes from testosterone primarily. And so we want you to have the desire for intimacy so that you can have the fertility impact and the implantation, excuse me, not implantation, but conception, so that implantation can later happen when you grow your progesterone. So it makes sense that your testosterone would boost just a little bit, give you an extra pep in your step around that ovulation time period. And if we're looking at that window, we're trying to capture your total testosterone somewhere around 50, deciliters per, not deciliters, nanograms per deciliter, and then your free testosterone maybe around 3 picograms per milliliter. Now, when that ratio is a little bit off balance, we can diagnose what we formerly called PCOS. That helps us sleuth through. It can also help us sleuth if you have some adrenal disorders, if we see imbalance in those ratios and those numbers too. So it's useful. It's just very useful to kind of sleuth through what's going on. In a perimenopausal female, like I said, there's no real, quote, normal. Perimenopause, unfortunately, we just say is no man's land when it comes to all the labs to some degree. But we would expect to see a little bit of a detransition and a downward fall. And then postmenopausal females, obviously, we would expect to see less than what an ovulatory female is producing. However, of the 3 hormones, estradiol, progesterone, and testosterone, it is the last to kind of go, because if you think of the functions of testosterone, what do you need it for? Libido, still important as we age. Muscle mass strength, primarily one of its best preservations and functions in our body. Mood, well-being, can be a mitigator of headaches and can help with sleep, lowering cortisol. Testosterone still is very relevant to our daily functioning, so we want you to have a little bit of it, but probably just not as much as when you were ovulatory, because the purpose of that hormone was for impact of fertilization and libido. So anyways, what do we shoot to when we're trying to optimize hormones? There's actually a lot of research in bioidentical hormone therapy that supports superphysiological level use of testosterone, meaning in a postmenopausal female, I'm probably going to try and get you back to at least that 50 on the top number, but more preferentially, it's permissible to get you as high as 100 to 300. Shocker, I know, but that's why if you read your lab slips and the reference ranges, you need to be with your clinician on LabCorp. This is what I'm saying. This is not on Quest, but on LabCorp. Because you might see lab level high and really we have it under control. On your free testosterone, you could see it as high as 3 to 5, or expect 3 to 5 on that when we start a hormone therapy script on you with testosterone cream, for example. And that's where I'd be trying to get you to if you were postmenopausal and we're trying to resolve some issues, symptoms of low testosterone, and get you back into the optimal wellness and health range. So those are some of the expectations I just wanted to talk about. Again, obviously when you're reading lab reference ranges, it depends on the lab company you're using, the purpose of the use of the hormone, whether you're on therapy or off of therapy. That will, help us understand what those levels mean as well. And so talk to your hormone provider always about the lab reference ranges and what they truly mean, what they're reflecting, and is high high or is low low, because there could be a lot of misconstructions and misunderstandings depending on what's going on. But I wanted to talk a little bit about lab reference ranges and some of the expectations in pre, peri, and postmenopausal females. I should mention males, a little different when we're talking about total and free testosterone. We're looking at much higher lab value sets. For example, in males, depending on your athletic pedigree, your weight, and some other factors that influence our interpretation of things. Again, super physiological concentrations of testosterone are not totally unsupported to try and shoot you on total testosterone, 900 to 1200, again, nanograms to deciliters, and then on free testosterone, somewhere between 25 and 40 on picograms per milliliter. And that would not be totally abnormal or unsafe per se. And so wanted to give you those reference ranges of optimization and what we'd be looking for in someone who is using a testosterone cream or perhaps injection for the purpose of metabolic health and then not fertility. It's a whole other story. You don't want to use testosterone injections and cream if you are rendered or needing to produce a child or want the fertility conception, because testosterone cream and injections can lower your sperm count, actually make you a little bit infertile. So we need to talk about that, but I digress. Testosterone, talked mainly about females, but on males it matters too. We have different reference range units for both, and I just want to give you a little bit of an idea of what we're looking at when we come into a bioidentical hormone therapy appointment together. Depends on who you are, where you are in your journey, what lab we're using, any methodologies, products, creams, etc. that you have going on, and we will always figure it out for you.